right, we're gonna go ahead and get started. My name's Lexi. I'm a just brand new PGY4 for all the med students and new interns I haven't met. So just mainly we're gonna focus on the presentation and workup for gallbladder cancer and then the subsequent treatment algorithms afterwards. But we'll go into a little bit of brief epidemiology at the beginning, as well as some tidbits about chemotherapy at the end. So just really quick, talking about how prevalent gallbladder cancer is. So it's the 5th most common GI cancer in the US. Incidence is fairly low, 1 to 2 out of 100,000. It's a little more common in a few other Southeast Asian countries. And then it does predominantly affect women in a 3 to 4 to 1 ratio. The overall survival is pretty low for all comers diagnosed with gallbladder cancer at about 19%. But depending on the extent of disease, if it's only localized to the gallbladder, 5-year overall survival is a little bit higher at 65%. Regional disease, so some local spread or spread to local lymph nodes, 28%. And then if it's metastatic past that, then prognosis is very low. So the median survival, if this was an advanced untreated gallbladder cancer, would be about 2 to 5 months from time of diagnosis. And just to keep in mind, these often present late. So while we're going to talk a lot about surgical options, only 20% of patients at time of diagnosis actually have an option for curative resection for gallbladder cancer. So there are commonly 2 ways that gallbladder cancer presents. Maybe one of the interns could name a couple of ways it might present. Yeah, so Ryan says, incidentally on a lap chole, that's perfect. That's actually the most common way that we find it these days. And what's another way it presents? Yeah, so symptomatic. So typically they present with abdominal pain. They might come in with nausea and vomiting, jaundice, as you said, and then weight loss like a typical cancer patient. So on cholecystectomy, a couple of facts to know. So most patients with gallbladder cancer have gallstones, but that doesn't necessarily mean that if you have gallstones, you're going to have gallbladder cancer. So only up to 2% of patients who have gallstones will actually have gallbladder cancer. So it doesn't necessarily mean that it's causative, but if you're going to have gallbladder cancer, you most likely had a history of stones. And if they're larger stones, you have a much higher risk of having gallbladder cancer, especially if they're greater than 3 centimeters. So we talked about common symptoms of if you present with symptoms with gallbladder cancer. You also might have hepatomegaly or a palpable gallbladder because if it's fully obstructed, it might be fluid filled and prominent on exam. Just a fun tidbit, does anyone know the eponym for that physical exam finding? Yeah, perfect. So Tommy says Cuvier sign. I did practice that one. Courvoisier sign. I tried to practice it, but yeah, so it gets really distended. You can actually feel the hard palpable gallbladder at the right upper quadrant. Also common with an obstructive pancreatic head carcinoma. So before we talk about staging of gallbladder cancer, it's important to understand the anatomy of the gallbladder. Mm-hmm. So for the listeners on Zoom, Alex Nissen asked about porcelain gallbladder. So the old thought was that porcelain gallbladder was related to gallbladder cancer, but the studies have borne out that it in fact is not related to cancer at all. I wasn't going to talk about it, no, but. I guess for the inference, is it more would be a higher risk of cancer to porcelain gallbladder or some yeah, that's much more concerning for gallbladder cancer. Yeah. And then gallbladder polyps. I was not, but gallbladder polyps is kind of its own entity, and you would want to take a, you would want to do a cholecystectomy for a polyp 1 centimeter or greater, or one that's growing over serial ultrasounds because of risk of finding malignancy. Every 3 months, I think, for greater than 5 millimeters. But yeah. Okay, so to talk a little bit about gallbladder anatomy, maybe Jen can talk to me about the layers of the gallbladder wall. I think I saw her walk in. There she is. Whoop, sorry. No, yeah. Mm-hmm. Yeah, correct. Yeah, correct. So Jen says that gallbladder doesn't have a submucosal layer, and also that the part of the gallbladder that is against the liver lacks a serosa as well. So just has this paramuscular fibrous tissue up against the cystic plate. So this is important when you start staging gallbladder cancer, because you can imagine if the tumor is invading to the paramuscular fibrous tissue, that's the plane you're taking the gallbladder off in a cholecystectomy. So if the cancer reaches that plane, you're going to have to do further surgery to clear your margins. Is kind of the long in like the message of that. But so T1A goes into the lamina propria, T1B into the muscularis layer, and then T2 goes into that paramuscular connective tissue. T3 penetrates through the serosa into at least one surrounding organ, and then T4 is multiple organs or involvement of the portal vein or hepatic artery. So the important thing to keep in mind is once you get to this muscularis layer, this is where the blood supply and the lymphatics lie. So as we start talking about treatment algorithms, we start talking about taking a lot of lymph nodes because once you get into that muscularis layer, your rate of lymph node spread goes up significantly. So this just kind of reemphasizes the T staging. Another important point that we didn't touch on for, sorry, it's advancing. For AJCC8, they also made a distinction between, for T2 cancers, whether you're on the peritoneal side versus the hepatic side. So peritoneal being T2A and the hepatic side being T2B. For lymph node metastasis, you're looking at in1 disease being in 1 to 3 nodes and into greater than 4, and then our typical metastatic staging. So once you get to nodal disease, you're talking about stage 3 gallbladder cancer, as well as getting to T3, so outside the serosal layer of the gallbladder. And then once you get to T4 or any more significant nodal involvement, you get to stage 4. So we're going to talk a little bit about the workup algorithms. As far as if you know that this patient has gallbladder cancer preoperatively, some of the imaging that you want to get to further work it up. Likely you already diagnosed it on an ultrasound if they're coming in with right upper abdominal pain and jaundice, and you can look into the layers of invasion using that, but an MRCP will give you a lot more finer detail as far as that goes. The CT will show you more detail about vascular involvement, like Dr. Freeland was talking about on Monday. And then you also, while it has a preference for spreading more lymphatically, it can spread to the lungs as well. So you want to complete your staging with a chest CT. The PET scan also has a role because it's the most sensitive for lymph node spread. And as we'll talk about resectability of gallbladder cancer, one of the big things you're looking for is distant lymph node spread into the aortic cable or celiac nodes. So this is the most sensitive way to evaluate your lymph node status before you get to surgery, but it's also expensive and you can't always get insurance to pay for it outside of the military. Something else that's very important for your staging before you start talking about radical resections is a diagnostic laparoscopy. So what these imaging studies don't really pick up are peritoneal mets if they're not very large, and peritoneal mets in gallbladder cancer makes it unresectable. So you always want to start with a diagnostic laparoscopy before you do a big hepatic resection on someone. So just to define when it is unresectable, so if you do have distant hematogenous or lymphatic metastases, and what's defined as distant for gallbladder cancer is those aortic cable or those distal peripancreatic nodes, and I'll have some more pictures of that coming. Peritoneal disease or any major vascular involvement, so the SMA or celiac axis and the associated aorta, of course, or vena cava. At this point, you would want to consider more palliative options instead of doing a hepatic resection, or won't benefit these patients' survival. So just to kind of keep in mind how these patients present, they're unresectable. 20% of them I'm sorry, I have that backwards. Only 20% of them are resectable at the time of diagnosis. And then when you do your diagnostic laparoscopy, despite thinking that you've picked adequate surgical candidates up front, half of them will still be unresectable at time of laparoscopy. So that's why it benefits these patients to put a camera in first instead of proceeding to a big exploratory laparotomy and then finding distal disease or distant disease. So for patients when it's an unexpected finding, this is one of Dr. Krell's cases. So a 74-year-old woman presents with cholecystitis. Obviously, it's a very inflamed gallbladder. It's a tough case. They have to convert to open, and the path, but they don't necessarily realize that it's cancer intra-op. Comes back as a T2 gallbladder cancer with no positive nodes on that pathology. So now what should we do at this point? We found gallbladder cancer incidentally. Maybe Maria or Carson. If it's T2. So yeah, so you want to finish your staging workup. So T2, so that's going into that perimuscular tissue, if we remember from the anatomy, and that's past where the lymphatics live. So your rate of lymphatic spread is higher. So you aren't done resecting with a simple cholecystectomy with this patient. T1A, you're done. We'll go through these again, but T2 and up, you're not done necessarily. So you want to, I'm sorry? T1B is controversial as well. Yeah. So you want to complete your staging. You want them to recover from their initial surgery, especially after an open cholecystectomy, and then try and get them ready for a liver resection if needed. And then there's a lot of debate over what this ideal time window is to go back for the curative resection, but based on some retrospective studies, there's, sorry. What's the debate? Why not go back right away? So you don't want to go back right away. They're not ready to, they just underwent surgery. You don't want to have a second shock to the system. You probably don't get path for 2 weeks and your adhesions are like crazy at that point. So you have high risk for iatrogenic injury. And then you don't want to wait too long. So you don't want the cancer to spread either. So.
Are you talking about a lap chole, Lexi?
Well, this lady had an open colon.
Oh, that lady, yeah. I mean, that lady was very different though, right? But a lap colon, you could go back whenever.
Okay.
Yeah, I wouldn't be afraid to go back in 2 weeks from a lap colon, but yeah, a big open cholecystectomy and a nightmare gallbladder, that's one thing.
And this particular patient's case, we got a giant question. But you can, if there is an old age or sick, if it was a peritoneal site TQ or really who knows, on top of it, you can make an argument. Surgery in the context of all this. But if you look at imaging and everything, there's some chance we're having that. So that was the difference. Unfortunately, we didn't have much time. Wait, could they give you a cystic deficit? But for the tumor itself. This was a tumor that's in the liver, so it's a liver. Or decide with the liver on it, the liver side. So anyway, yeah, exactly. What do you know? Why that specifically about that tumor? Because that really helps you plan.
So we've already stressed starting with the diagnostic laparoscopy. And again, if you go back for the definitive resection, even if your pre-op imaging doesn't show any distal disease, there's a 50% chance that they're unresectable due to peritoneal mets or distant lymph nodes. And then the AHPBA and SSAT, and I'll recommend starting with a frozen section of at least an aortocaval lymph node before proceeding with definitive resection. And if that is positive, that indicates distal lymphatic spread and you stop.
So how do you talk me through how you use that aortocaval node?
So I would do a mobilized hepatic flexure and do a Coker maneuver. And then I would take, I think that's like station 14, but no, Dr. Carl's shaking. But you would go and fish out the perilymphatic tissue around the IVC and aorta after you do an extended Coker.
Yeah, I mean, so as you do that Coker, you uncover the cable, right? So how do you, what structure are you looking for to say that I've done a complete Coker?
The left renal vein.
Great. So, basically you can take everything below that plane is the aortic cable node. Above that is peripancreatic. There's sort of that Coker point. So you can basically take any node. I would go as high towards the gallbladder as you can, that's going to be kind of the first range gallbladder nodes. Cable nodes. So usually there's kind of a space that's right above the right renal vein. Take one of those nodes. You can feel an enlarged node. Take that. Sort of feel an enlarged nodes. You can grab something, but then I think it becomes less.
Cancer, so this lady's pick back travels the parts that we spend a lot of not all cancers go there. This one's great.
It's not very well. You're just saving them. It's not. You're not helping them. It's not trying to clear out those patients. It's a staging thing. All right. Go
So as far as planning the extent of the resection you need to do, so this is all related to what layer it penetrates and what their risk of lymph node metastases will be based on what layer it's in. So we covered if it's T1A, just in that lamina propria, then a simple cholecystectomy will do because the risk of lymph node metastases is quite low. Once you get to T1B, it's debatable. Technically, the right answer for a young, healthy patient who can undergo the surgery would be a radical cholecystectomy, including all the things we're about to talk about. But if you have an older patient that a hepatic resection might be more morbid for, you can just opt to surveil them and kind of have that conversation with the patient. So for T2, gallbladder cancers, you proceed with a hepatic resection. So the classic teaching is to do a segment 4B and 5 hepatic resection, but there's new thought that you can just do a wedge resection. So taking a 1 to 2 centimeter margin above the cystic plate where the gallbladder used to be, and that is adequate. And some people are able to do that even robotically or laparoscopically as well. And then you also have to complete a portal lymphadenectomy. And then if that cystic duct margin is negative, you re-excise the bile duct. It used to be routine that you always re-excise the bile duct, but it wasn't shown to add any survival benefit unless it was positive. So, if it's positive, you re-excise it. If it's negative, you leave it alone.
Okay, so
no.
if it's positive, you re-excise it.
Yes.
Okay. You took a flush with the common bile duct positive, what are you gonna do?
You can do a common bile duct resection and do an HJ. Some people even describe if it's extensive enough, but without distant metastasis, you can do a Whipple for these as well. That's like rare, but it is described.
Good enough for
Yeah, I mean, I would do an extrahepatic bile duct resection that's relatively low morbidity, but you know, if it was the wrong old patient where you're like, I don't do this, like you might not. That's a really bad prognostic. When you send that to a person, or do you take what you're saying? No, I would possible. Oh, what do you mean? What do I take? Frozen from the bile duct? No. Yeah. Only because what are you going to do with that information? I would take as much like. Yeah. Okay. You're not taking. I mean, I guess maybe if you thought you could go higher on the proximal instead of frozen, but maybe, you know, so the other hepatic radicals that could do, but you didn't want to. That would be a good rationale, but. Yeah, but I probably would not. Because it's the same reason. If it's spreading that far, yeah, probably.
And so for T3, T4, you would do the same as you did for T2, but the likelihood of a more major hepatic resection is higher just because you do have invasion into the liver if it's on the hepatic side. And then whatever involved organs, this is assuming you don't have distal lymphatic spread or peritoneal implants or metastatic disease, you would do an in-block resection. That might be like a gastrectomy. We said like up to a Whipple. Or excising some of the duo as needed. So as far as what that segment 4B and 5 resection looks like, you're taking this right anterior part of the liver, and this is an intra-op photo from Dr. Krell marking out those segments.
back. Not everybody does that. I don't do that all the time. This is the right mark.
And then you also perform a portal lymphadenectomy. So the goal is to get at least 6 lymph nodes. And that number is based off of a prospective cohort out of MSK. They showed not only does it better indicate your prognosis for gallbladder cancer, but there's actually a survival benefit as well if you take at least 6 nodes from a patient, regardless of their T stage or status or lymph node status. So you're mainly going after these station 8 common hepatic nodes and the station 12 porticable nodes as well. So, and these are kind of illustrating which lymph nodes you're going after. And this is, again, one of Dr. Krell's intra-op photos that shows a very well dissected out portal lymphadenectomy. So for this patient, this is 5 months after her initial open cholecystectomy, where we found T2 gallbladder cancer. We are kind of running out of time. So we see that there's maybe this resolving hematoma versus maybe there is some residual tumor left. And so our plan at this point would be to make sure we stage appropriately and do a diagnostic laparoscopy, but she would need a radical cholecystectomy, including some hepatic wedge resection and portal lymphadenopathy or lymphadenectomy.
Up to 3 months totally fine. But yeah, 3 months thing is weird.
So a really quick overview of chemo in 2 minutes, but so one of the landmark trials was the SWOG S0809 study. So this looked at adjuvant capecitabine and gemcitabine, followed by radiation and concurrent capecitabine. This was more of a, I guess, proof of concept study. So there were no like randomized arms or anything like that. It just established that this regimen was safe and tolerable for patients. They had some benchmark survival that they wanted to see. So 65% 5-year overall survival estimated for an R0 resection, 45% for an R1, and they were able to meet those benchmarks. So this just kind of established its feasibility. The BILCAP trial, so this included both gallbladder cancers and other biliary tract cancers, and this looked at adjuvant capecitabine after resection versus observation. And although technically they didn't have significant p-values in their intention to treat analysis, but as you can see, there is a trend towards a benefit in the capecitabine group. And then when you look at their per protocol analysis, meaning that those patients completed at least 1 cycle of the capecitabine in the treatment arm, there was a difference in survival for the patients receiving capecitabine. So technically negative, but a lot of people still think capecitabine has a benefit adjuvantly. Yeah. So some another regimen. So the ABC2 trial looked at gemcitabine and cisplatin versus just gemcitabine alone, and this was in metastatic or advanced gallbladder cancer. This was not surgically resected gallbladder cancer, but it did show that there was a survival benefit to getting multi-agent chemotherapy for these patients. So this is kind of become another standard regimen of giving this multi-agent therapy for gallbladder cancer. And there's a current randomized controlled trial enrolling right now, looking at adjuvant gem plus cisplatin versus observation, called the ACTICA-1 trial. There's a couple other ones looking that I got briefly before this, looking at like gem-ox that showed no benefit. And then there is a neoadjuvant trial that I'm blanking on the name of, looking at gemcitabine and cisplatin, but it also didn't show any survival benefit in that trial either. And then there's some, I wasn't able to access this article in time, but there's one looking at perioperative chemotherapy called the opt-in trial. So these are for patients that they incidentally were found to have gallbladder cancer, and then you stage them and you're planning to do a radical resection, and you give them several cycles of capecitabine preoperatively before their radical resection, and then continue it post-operatively as well. But maybe Dr. Krell can speak more to what the findings were.
No, it's still a drone. So
okay.
incidental gallbladder into this one,